Okay, I am doing a femur series, and we're going to start with the AP distal femur. I have my SID at 40 inches. The CR is perpendicular to the femur and the IR, and I am using a 17 by 14 inch cassette lengthwise. First, I'm going to put some shielding on the patient for the distal femur. The CR should be directed to about mid-femur, and you want at least 2 inches of light below the knee joint. I'm going to collimate down. For the distal femur, you want the patient's foot rotated medially about 5 degrees to put it in the knee into a true AP. I'm going to put my right marker in the corner, away from the anatomy, but still in the light. The structures best shown on this are the distal 2/3 of the distal femur and the knee joint. The knee joint will appear closed because of the divergence of the beam. There are no breathing instructions for this, so you take the exposure and then we'll move on to the AP proximal femur. For the AP proximal femur, you probably won't be able to use shielding because it will obscure the anatomy that we want to see. You also have a 40 inch SID and a 17 by 14 inch cassette lengthwise. You want to make sure that there's at least 3 inches of overlap on your films, which there will be. And you want light at the ASIS. Okay. And collimation is good. I put my marker down in the corner in the light but out of the anatomy. And the structures best shown on this are the proximal 2/3 to 1/2 of the proximal femur, the acetabulum, and the surrounding ilium, ischium, and pubis. So, exposure, stop respirations. That's it for the AP femur. Now we'll move on to the lateral. For the lateral femur, you also have for the distal lateral femur, you have a 40 inch SID and a 14 by 17 inch cassette. We're going to have our patient roll so that they're in a lateral recumbent position with the affected side down. So I'm going to have you roll into your right side. You want to make sure that the patient's unaffected leg is out of the imaging, so you can put that, you can support it with a little foam, and then have the knee at about a 45-degree angle. And move our table. Once again, you want light at least 2 inches below the knee joint for the distal lateral femur. And then you can turn the collimator head so that it goes along with the long bone of the femur. CR is once again perpendicular to the IR, and you want it midline with the femur. Although remember that the femur is closer to the anterior side, so let's keep that in mind. And then I put a marker in the light but out of the anatomy. Collimation is good. Shielding for this. And then there are no breathing instructions for this exposure. The structures best shown are the distal 2/3 of the distal femur, the knee joint, the distal condyles of the femur will not be superimposed, and the knee joint will appear closed because of the divergence of the beam. Moving along to the lateral proximal femur. For the lateral proximal femur, you may need to rotate your patient slightly so that none of the anatomy superimposes. I'm going to move them down so that you have light at the ASIS. Once again, put the marker in the light but not in the anatomy. We might have to collimate it out for this one. And there are no breathing instructions, and you won't be able to use shielding because of the anatomy you're trying to visualize in this film. The structures best shown are, once again, the proximal 2/3 to 1/2 of the proximal femur and the hip joint.